Good morning, everyone. It's a great pleasure to introduce one of the preeminent researchers in medical image analysis, computer vision, and machine learning. Dr. Tal Arbel is a professor in the Department of Electrical and Computer Engineering at McGill University, where she is the director of the Probabilistic Vision Group and Medical Imaging Lab in the Center for Intelligent Machines. She is a Canada CFAR AI chair and associate member of Montreal Institute for Learning Algorithms, or MILA, and of the Goodman Cancer Research Center. Professor Arbel's research focuses on development of probabilistic machine learning methods in computer vision and medical image analysis with a wide range of real-world applications in neurology and neurosurgery. For example, the machine learning algorithms developed by her team for multiple sclerosis lesion detection and segmentation have been used in the clinical trial analysis of most of the new MS drugs currently used worldwide. She is a recipient of the 2019 McGill Engineering Christoph Beer Research Award. She regularly serves on the organizing team of major international conferences in both the medical imaging and computer vision fields. She was an associate editor for IEEE Transactions on Pattern Analysis and Machine Intelligence and Computer Vision and Image Understanding, and is now the editor-in-chief of a newly launched archive overlay journal, Machine Learning for Biomedical Image Analysis, or MELBA. So I should note that MELBA has a very exciting publication model in which it doesn't charge exorbitant publication fees. Rather, there's a small fee, a very small fee for submission, which I think is really a great model. So welcome, Dr. Arbel. We look very much forward to your talk whenever you're ready.
Thank you so much, Roger, for that very kind introduction. I'm very excited to be here, and thank you for inviting me. So today I'm going to talk a little bit about a specific area of research that we've been working on modeling and propagating uncertainties in machine learning for medical images acquired from patients with neurological disease. So that'll be the focus of today's talk. And okay, so as we know, machine learning and medical imaging really does have the potential to make huge advances in medicine and healthcare, helping in patient diagnosis, for example, diagnosing this person has breast cancer, understanding disease development, for example, predicting that this person will get Alzheimer's, predicting patient outcome from images, so for example, survival time for patients with tumors or cancer, speeding up and making accurate clinical trials for new treatments. So for example, here you could see a patient with a tumor that is shrinking over time, and therefore this patient is a responder to treatment, and permitting advances in personalized medicine. So for example, determining that this patient will have no changes on a specific treatment, and therefore the treatment will work for them. This is predicting like the future for that patient. And even though we've made huge advances in machine learning for medical imaging, we have a lot of very successful frameworks for segmentation, for classification. Many of the approaches are not really widely integrated into real clinical practice. So the question is, why is that? And there are a lot of different reasons for that. One thing is, of course, we know machine learning algorithms are often developed in computer science or engineering labs where we often don't have access to large-scale annotated data sets for training. But also, we don't typically have access to the clinicians or to the clinical needs of clinicians as we develop our methods. A lot of the field is really focused on developing frameworks based on smaller proprietary data sets, for example, benchmarking or these challenge data sets. And as a result, they're not necessarily robust to patient and data variability across different centers, scanners, disease stage, and so on. And furthermore, because we focus on a lot of these benchmarking data sets, they're often optimized for established metrics of success. For example, metrics that are very common in computer vision or in machine learning, but they may or may not be important for the specific clinical task of interest. So In general, medical imaging is hard. It's not just a subset of computer vision. It has its own unique challenges, and there's a lot of uncertainties. If we look at the specific problem of automatic segmentation in medical imaging, we know, for example, on the left, you can see an example of a task in computer vision for segmenting objects in a data set. So machine learning techniques developed for that kind of problem really are focused on getting the boundaries right. I mean, they don't have to be perfect, but generally segmenting objects, and you can see the type of difficulty in that task. And some of these machine learning approaches can be appropriate, for example, for segmenting known healthy tissues. So here, for example, you have known structures in the brain, and you focus, you know exactly the region of interest they are, and you really want to delineate the boundaries properly. But machine learning models developed for computer vision don't always work well enough for medical imaging problems to be used in the clinic, particularly in the presence of pathologies like lesions and tumors. These really present challenges to popular machine learning methods. So in this talk, I'll talk a little bit about why it's important to model and convey uncertainties in deep learning models for medical imaging analysis in the context of patients with diseases, neurological diseases. And I'll tell you a little bit about some work we're doing on propagating uncertainties across cascaded medical imaging tasks. And we show that they can be helpful in improving deep learning inference. And we're going to focus on 2 case studies, really deep learning for detecting and segmenting brain tumors and multiple sclerosis lesions in patient MRI. So we focused a lot on multiple sclerosis lesion detection and segmentation. These are some of the students that have worked on these projects for, I've been working on this for almost 20 years in collaboration with Doug Arnold from the Montreal Neurological Institute and NeuroRx, and Doina Prekup at McGill and Mila and DeepMind. So I'm just going to give you a little bit of background on some of our work quickly, and then we'll head to some recent work. So as many of you know, multiple sclerosis is the most common neurological disease affecting young people. The most common form is relapsing remitting, where the patient gets intermittent attacks or relapses followed by full or partial recovery. And the other stage is, of course, the progressive stage, where you have a progressive increase in disability without a relapse. So one of the hallmarks of MS is the appearance of these multifocal brain lesions on MRI. And at the top, you can see in red some lesions on a patient image. In the context of relapsing remitting disease, on the bottom, you can see different sequences of MRI, and these are images of patients over time. And one thing you'll see is as the patient evolves in relapsing remitting disease, lesions appear and partially or fully disappear over time. So T2, meaning lesions that appear in T2 images are important because T2 lesion count and volume has been used to estimate burden of disease. There is no cure at the moment. Treatments can suppress new lesions or manage symptoms, but not to fully stop progression. So in order to develop new treatments, we really need clinical trials. And so in clinical trials, we need much more than just T2 lesion segmentation. We need other markers to measure disease activity. For example, the number of new T2 lesions in longitudinal MRI and the number of gadolinium enhanced lesions in T1 MRI. So I'll talk to you a little bit about those in a sec. These are really used to determine the treatment effect and used as endpoints in clinical trials. The problem is manually or semi-manually delineating these lesions is really slow, very expensive, and very inconsistent even for trained raters. So we really need automatic techniques for robustness and consistency. So this is something we've been working on for many years. I'll just tell you about the 3 problems in a little more detail. To assess MS activity, we really need to segment all the lesions, even the small ones. So these are T2 lesions in a bunch of different patients. You can see some of the challenges. Some of the lesions are very, very small and hard to detect. And you have a variety of small and large ones. Sometimes you only have one tiny one in the image. This is one patient through their slices. So T2 can be hard to detect. The appearance of new or enlarging T2 lesions on successive MRI scans is also important. And so here you see reference and follow-up, and then you can see on the right the new and enlarging lesions that have appeared since the previous scan. And it's really hard for for radiologists to identify these new lesions visually, because you really need to differentiate the intensity differences that took place due to lesional activity from other artifactual intensity differences. So for example, here's the subtraction of baseline and follow-up. Typically, we do look at the difference image, and you can see here that there are a lot of differences in the image that are not due to necessarily new lesional activity. It could be even artifacts or registration errors or other kinds of changes. Gadolinium-enhanced lesions are also really important as a marker of current disease activity. So you can see here, here's an image before gadolinium enhancement. Here's after the patient is injected with a contrast agent. And you can see some sort of enhancements in the image. And our goal is to find the enhancements that are due to the MS disease, new lesional activity. And they're really hard to detect. If you look at the bottom, you can see an enhancement map. So the brighter parts are more enhancements between these two images. And you can see that there are a lot of enhancements in the image, and a lot of them are not due to lesional enhancements. They're like blood vessels and other things. So for example, in the red are non-lesional enhancements, and the green are the things that we need to find. So for example, these are the gadolinium enhanced lesions that we need to find. So my group has been working on all of these problems for many years. And earlier models were in fact probabilistic graphical models for MS lesion detection and segmentation. We placed it into the commercial software pipeline of our industrial partner. And they provide software analysis to the pharmaceutical industry for MS clinical trials for pretty much all the new therapies in the world. So for the company, the time-consuming and inconsistent manual or semi-manual analysis by the neuroradiologists were replaced or added to by fast, accurate machine learning methods. So for the company, that meant improved efficiency and savings in time and money. But more importantly, for treatment analysis, it really improved things because we are then able to have faster and more accurate treatment assessment. So as Roger was saying, and thank you, our tools are used for pretty much most of the new MS drugs recently approved and used worldwide. More recently, we actually got access to big data, which big data for medical imaging, not for computer vision. So with a grant for the International Progressive MS Alliance, we got the first federated clinical and MRI data set of both relapsing, remitting, and different kinds of progressive MS patients, pretty much all of the large phase 3 MS clinical trials. So we have tens of thousands of patient scans at from different centers, from different scanners. We have all different sequences at different time points with expert-generated lesion labels. So that's great. So the question you should be asking yourself now is, hey, we have big data, so can't we use deep learning to solve all problems with big data? So let's look at a little bit closer at this issue. So the issue that we're looking at here is just the context of T2 lesion detection and segmentation. So we have different MRI sequences as input. We have a variant of the UNet. It's a 3D UNet segmentation strategy, and at the output are the T2 lesion labels. So we ran it on a big clinical trial, different center, different scanner clinical trial, and we want to look at the results of the false detection rate versus true positive rate. So the first thing you should see in blue is the voxel level segmentation results, and it does pretty well at that task. And then we actually group voxels into lesions, and we do lesion detection results. And we have here in yellow the overall lesion detection results, which look really great. If you publish it, you get very good feedback. But if you actually sort of separate the results into lesion size bins, we will notice that it does really well on large lesions and medium lesions, which are up here on the curve. But if you just look at the small lesions, which are 3 to 10 voxels in size, we actually have very low sensitivity for these small lesions at an operating point here of false detection rate of 0.2. Really doesn't do well for those small lesions. The problem is in a lot of these trials, a lot of the lesions are small. And by small, we mean 3 to 10 voxels in size. In this trial, over 40% of the lesions were small. So what does that mean? That means if we hand the results with these kinds of errors to the clinician, this will really lead to mistrust. The clinician will look at these results and say they cannot rely on a system like this. So here's an example showing in green are the correct lesion labels that we found, but in red and blue are some false positives and false negatives. And this leads to a reluctance of adopting deep learning techniques into real clinical practice. So our conjecture, and this is some work from my student in my lab. Do we have the citation? No, okay, I'll get to it. What if we could instead quantify the reliability of the predictions in the form of an uncertainty? So predictions here are in the form of three classes. It's either lesion, non-lesion, or this new uncertain class. And so that you can see here with question marks. So information like this will be provided to the clinician in a similar way that, let's say, a junior doctor would refer to a senior when they're uncertain about a decision. And then they can go ahead and review the areas that they're not so certain about. And so our thoughts are uncertainty would then help accelerate the clinical workflow and not replace them and build some trust. So we developed some frameworks to produce and analyze different uncertainty measures in segmentation and detection of focal pathologies. And this is some work from my former student, Tanya, who was a master's student. And she investigated and explored different kinds of uncertainty measures for this task. She actually got one of the Young Scientist Awards for this work at McGill. So basically, you have multimodal MRI and input to a 3D deep learning metric. Again, this is network is a 3D unit. We get voxel level segmentation, and we analyze different kinds of voxel level uncertainty measures. And then we had lesion level detection, and we have uncertainty measures on that level as well. So what we did is we looked at the popular Monte Carlo dropout estimation methods proposed by Gall et al. And if you have a network that's trained using dropout, then at test time, you can take Monte Carlo samples of the prediction using dropout, and you can get statistics to approximate the uncertainty. So for example, you get different samples of the output, and then you can get a mean, and you can then estimate different kinds of uncertainty measures like mutual information or entropy or variance, and there's different statistics that you can get. Then once you have the voxel level uncertainties, what we showed is that you can then, when you actually detect the lesions, you can then accumulate the evidence in the lesions by actually using a naive Bayes assumption here by merging the lesion level uncertainty. So basically, the more voxels think that they're a lesion, the more the entire lesion, for example, would be more confident that it is indeed a lesion. So in order for uncertainty to enable clinicians and radiologists to review on the most uncertain predictions and really trust the most confident predictions, our uncertainty measures have to have a very specific property. When they're confident, for example, down here, they better be correct. And when they're incorrect, they should have higher uncertainty. So that's the criteria that we're looking for. And so how do we ensure that we have this criteria? Basically, we looked at filtering out the most uncertain predictions, and we should see an increase in performance in the remaining more certain predictions. Okay, so we had an experiment that we ran again on a big clinical trial. And we looked at both voxel level and lesion segmentation and lesion level detection with the predominance of lesion level uncertainty filtering. So just a couple of things I just wanted to show. So when you zoom in on a false positive that you've segmented, here's a false positive. One of the takeaway messages that we found is that the contours are often much more uncertain than their inside. Okay, so that no matter which of these sort of model-based uncertainty metrics we have, they vary a certain way, but it's always more uncertain around the contours, which makes sense. We don't actually have very good ground truth around the contours anyway, due to a number of factors. Predicted variance here is really about the data uncertainty, so it's a little bit much more noisy and depicting something else in this context, but that's beyond this talk. The other take-home message is that if we zoom in on an area of interest with small lesions, we find that all of these uncertainty measures are quite uncertain with these small lesions. So small lesions are much more uncertain. So if we actually then visualize lesion level filtering, we show a single MRI slice segmentation with entropy-based uncertainty thresholds. So here you see the baseline image. Green means it was confident and correct. This is a true positive, but we have here a false positive that we've zoomed in on. So again, if we threshold based on entropy, we find that the first thing to go is this false positive, meaning it has a higher uncertainty, much higher uncertainty than the true positives, which remain intact and are the system's very confident in it. So just to show us a little bit of the lesion level performance with uncertainty filtering, we see across different operating points and measures. So basically we have the baseline, and each one of these curves is a decrease in our uncertainty thresholds, meaning we're only considering more and more of the certain predictions. Okay, so we're filtering out the most uncertain predictions. And so each curve is a different uncertainty threshold and therefore a different percentage of the lesions retained at this threshold. And we can see from our baseline that we are over, so our baseline images over, our baseline's over here. And as we start to filter more and more uncertain lesions, then the area of the curve goes up. So that means that uncertain lesions are also incorrectly detected. And the reason is, if we do a little bit more analysis, is that the model doesn't really perform that well for small lesions. So if we actually focus here on the small lesions versus the medium lesions, that's really where it's doing its job. Classifying the small lesions as uncertain really improves performance the most. As we start to filter, we start to get rid of some of the small lesions that we're not sure about. And then that's where we have the biggest increase in performance gains. So we actually ran this also on brain tumor segmentation. We know that brain tumor segmentation is very important clinically for all of these reasons, diagnosing and staging and surgical planning. And we focused on the automatic segmentation of the tumor into different subgroups. So here you can see in green is edema, enhancements, and tumor core is, so enhancements are in light blue, and this is ground truth. And so basically, these are the segments that we see in the McGill brain tumor segmentation challenge, which is very, very popular. And so what we look at when we look at the BRATS challenge is that deep learning methods far outperform other methods on this challenge. But as we know, deep learning models can make mistakes. And so one thing that we did is we came up with a sub-challenge within the McGill challenge called the Uncertainty Quantification Challenge. And we did this along with Yaron Gal and his student. And what we did is we had everyone upload their segmentation results and their uncertainty results. And we ranked methods by how well their uncertainty metrics were working. Okay, so when you're confident, you want to be correct. And when you're not doing well, when you're incorrect, you want to be more uncertain. So what we did is we filtered the most uncertain voxels, and we calculated the metric of interest. Here it's dice on the remaining unfiltered voxels, and things should improve. So here are two examples showing this. Here we have whole tumor ground truth, our prediction, and then different thresholds. So you can see here in red, these are false negatives, and in blue, these are false positives. And as you threshold, what you want is that the blue and the red start to go yellow. Yellow means it starts to be uncertain. And the green area, which are the true positives, remain throughout, meaning they're confident and correct, and they don't get filtered. So aside from clinical review, how else can uncertainties help? This is another area of research that we've been exploring. And so that brings us to modeling and propagating uncertainty in deep learning in general. So these are some work with a variety of collaborators, both Yaron Gal again in machine learning, but also Malar Chakrabarty and Doug Arnold in the context of MS and Alzheimer's. So why is this, where did this come from? So we know that in medical image analysis, we typically have some sort of pipeline that performs a sequence of inference tasks before the task of interest, the downstream task of interest. So for example, in brain tumor, we basically know that first we have to do multimodal image registration, and then we do cell stripping, and then we do intensity normalization, and so on and so on. But we also know that there's errors at each stage, and these errors accumulate over a sequence of tasks, and they can really hinder the downstream task of interest. So what we started to look at is, supposing you have a sequence of tasks, all of them deep learning models for each of these inference tasks. So our hypothesis was, instead of just propagating the deterministic inference results from our deep learning models to our downstream tasks, why don't we also propagate the uncertainty across cascaded medical imaging tasks? And what we find is that it leads to an improvement in the inference results for the downstream tasks. This is a recently accepted TMI paper, but also a McGill workshop paper, which was part of this, that my student Raghav won best paper for. So again, I won't be able to talk about all the context, but you can ask me about it later. We looked at multiple sclerosis lesion segmentation, cascaded twice. So We also looked at segmenting the hippocampus and and then a downstream task of Alzheimer's score prediction, like cognitive score prediction. But here I'll just talk to you today about, in the interest of time, about brain tumor synthesis and segmentation. So as I mentioned, deep learning, again, for the BRATS challenge, this is how it works. Deep learning is very popular, a lot of 3D units. So you have different inputs, and basically it segments these different substructures. But for all of the approaches that are out there, we often assume that all of the MRI sequences are available. And we know that in real clinical practice, it's not the case. Often some MRI sequences are not available due to time and cost constraints, due to image corruption, patient movement, and so on. So this is a problem because we really want to have all of the MRI sequences. They do lead to improvement in segmenting things like tumors and lesions. So one of the things we looked at is, can we use deep learning to synthesize the missing MRI sequence and then send it to a tumor segmentation strategy, the fake image? And the fake image maybe could also be used to help a clinician with assessment. So our goal was as follows. You had 3 different images. These are the real images, and we synthesized the 4th. It's a 3-to-1 synthesis. We want clinically realistic images, so it's not enough to look pretty. And we want to really focus on the area of the tumor, because it doesn't matter as much if we're doing tumor segmentation if we aren't necessarily clinically realistic or perfect in some other faraway regions. So what we built is something called the RSNet, which is a regression segmentation network, which basically does multitask learning. So what it does is it's doing segmentation of the tumor while doing synthesis on the missing MRI sequence. And the intuition behind that is that if you are segmenting the tumor while synthesizing, the network will focus on the area of the tumor to actually try to do a better job in that region. So here's an example, and again, we didn't optimize this. This is not going to be a beautiful GAN image, but I want you to ask yourself if you can tell which is a fake image, which probably you can. One of them's fake and one of them's real. So again, we take 3 images and we synthesize the 4th, in this case, the flare. We repeat the task for the other sequences. And what we did find was that generally for T1 and T2, it did pretty well. For T1C, that's the post-contrast image after injecting a patient with a contrast agent. We can see that it has some trouble with the enhancement around and within the tumor. Of course, this is expected. It's a very hard problem because the other sequences do not have injected contrast agents. And so there's key missing information. And in the flare, it does pretty well, but it makes a few errors. So this brings us to the issue of cascading inference. So for example, there's 2 tasks here. One that we basically synthesize the missing image, and then we send it to a well-tuned segmentation strategy. And we want to see if we have a degradation in performance by replacing one of the real images with the fake one. And so here we have, this is the Sashimi paper 2018. We have the BRATS 2017 data set. And what we're showing is the results with the real image are all ticked here, and the results here on DICE scores for 3 different tumor subtypes: the enhancing tumor, whole tumor, and tumor core. And so what we want to see is if you actually replace the T1 or the T2 and so on with the fake image, is there a degradation in performance? So again, we see with T1 and T2, we don't have a big degradation in performance. We lose a little bit with flare, but for T1C, we have a big degradation in the DICE score for the enhancing tumor and its related tumor core. So that led us to think, okay, it does, this is understandable, but one thing we want to know is, can we actually produce uncertainty in the regress sequence? So for example, we take RSNet, and once again, we do Monte Carlo dropout estimation. We get many samples of the synthesized image. We get a mean synthesis and an uncertainty here in the form of variance. And what we find is that, if we look at the uncertainty, it's quite confident and it does a pretty good job with T1, T2. But for T1C, where it makes quite a few errors in the enhanced region, the system is telling us with this bright spot that it has high uncertainty in those regions that it's getting wrong. So that's good because that allows the clinician to basically take that synthesis in that area with a grain of salt. And so it also, much more importantly, brings us to this issue of uncertainty propagation. So instead of just propagating the synthesized image, what we proposed here at this Unsure workshop is that let's also propagate this uncertainty to the downstream tumor segmentation task and see if that helps. So here's some quantitative results on the hard part, T1C synthesis and FLAIR. And just comparing if we had 3 sequences, if we had sequences with synthesized images, and then the uncertainty. And we find that with the uncertainty, we have statistically significantly better results, particularly in the enhanced area. Again, these are really hard open problems still. We have not solved the problem yet, but we have some significant improvement. But I think it's very important is that numbers only tell part of the story. So let's look at the qualitative results for a second so you can see how it's doing. So here we have another sort of just showing you a little bit. We have the ground truth in this column for T1C synthesis, and here's for FLAIR. So we have yellow is enhancing tumor, green is edema, red is non-enhancing core. So these are the synthesized images. You can see here it does pretty well, but basically you can see even for the FLAIR, you have a bright spot within the ventricles. And so if you actually do segmentation with the synthesized MRI, there are some big errors, big non-enhancing core here. There's a missing non-enhancing core here. And here, because of this bright spot, our system thinks that there's edema or swelling within the ventricles, which is filled with actually fluid. So that's not possible. But if you then examine the synthesis uncertainty, it's very uncertain where it's incorrect. And you can see that within the ventricles, it's really not sure. So the segmentation with the synthesized MRI and uncertainty can be seen on the right here, and you can see that it is a big improvement in terms of its results. The non-enhancing core appears here, and you have a big correction here of the edema within the ventricles. So again, DICE tells part of the story, but it doesn't tell the whole story because clinically that makes much more sense. But it's not a big area, so it doesn't affect the DICE as much. Okay, the last thing I just wanted to talk to you about today is some very, very new work that we just presented at McGill. And so again, let's focus a little bit more on contrast-enhanced imaging. So we know that contrast-enhanced imaging is really important for determining treatment and efficacy, patient prognosis, tumor grading, and these T1C images or contrast-enhanced T1 really does play a crucial role in the segmentation of enhancing tumors and lesions in many contexts. At the bottom, you could see cancers and other contexts as well. But again, like I said, to get a T1C image, the patient is injected with a contrast-enhancing agent called gadolinium, and that is invasive and is no longer thought to be safe. So what we were focusing on in this work is, can we reliably segment enhancing tumor without T1C? Because it really would have an enormous impact. Can we do better than what we already did? We already saw that synthesis is hard. Even though adding in uncertainties does show improvement, we want to be able to do better. And again, there are some modality agnostic methods that were performed specifically for this task, HEMIS and UVED. And then, so these propose performing in segmentation in a modality agnostic way. But again, for this task, the performance in segmenting enhancing tumor really does degrade substantially when the T1C image was missing. So it wasn't the focus of that work. So this brought us to this area of research. Can we do better at segmenting enhancements associated with new disease without injecting the patient with a contrast agent? Can we do better than we did already? And so this led to a kind of new method called the HADNet, which is a hierarchical adversarial knowledge distillation network to improve enhanced tumor segmentation without the post-contrast images. Some work with Professor Jim Clark at McGill and some collaborators. So the idea is kind of simple in the sense that we built a network that is a knowledge distillation network. And the idea is that you have a pre-trained teacher network with access to all of the images. And it's used to teach a student to produce better segmentations when this crucial information is missing. So here we have T1C missing. And so the idea is that our goal is, we know that there's a big domain shift in the absence of this crucial information during inference. And so what we did is we have these two networks. Okay, we have the student network and this the student network down here, the teacher network up here, and we have this hierarchical discriminator, which helps bridge the gap between the two networks through an adversarial model. And so what we're sending to our discriminator for knowledge distillation is both the results of the segmentation and a hierarchy of scales of features. And so the idea is to kind of combine the ideas from hierarchical discriminators, for example, from the GAN literature, with adversarial knowledge distillation, which is typically not hierarchical. So it's the first to kind of effectively combine these two components to permit knowledge distillation to really help it overcome the large domain shift that arises when you have missing crucial information during inference. So again, we have these three components. We have a teacher network, which is essentially a UNet, a 3D UNet, and the student down here, which is identical. The only thing that's different is the number of inputs. This one's missing T1C. And then we have this hierarchical discriminator. The teacher, once trained, is frozen. And the idea is that we pass the information downwards through this hierarchical discriminator. So the idea is that the teacher that's frozen, you have a pre-trained student, and the student again does segmentation as the teacher. There's a normal cross-entropy loss with the ground truth. The segmentation results, as well as the hierarchy of features here, is sent to an adversarial discriminator here. And the hierarchical discriminator is basically as an adversarial network to differentiate between the student and the teacher. But basically the idea is to try to get the student to look a lot more like the teacher. It's basically like a fake image and a real image in a GAN. Okay, so now it's spinning. I don't know why it's spinning. So to go to the next slide. Okay. So during inference now, basically, we just use this trained student HADNet based only on the pre-contrast modalities, meaning everything but T1C. So we had experiments on the BRATS 2019 brain tumor data set, and we evaluated our HADNet with some competing models. Okay, so what are the competing models? We basically have something called an ADNet. The ADNet is the non-hierarchical version where it only has this one layer here of in its adversarial component. We have the pre-trained student, the frozen teacher. We have a recent, a variant of the recent knowledge distillation or KD network that was proposed in 2020 that showed some success in segmenting brain tumors when only one sequence is provided during inference, but we adapted it to our needs. And the main idea here is that we have a KL loss at the bottleneck. That's where the information is shared in the context of KDNet. We also compared it to these modality agnostic variants, which were run on the BRATS system. So again, let's see how we do. We look at the DICE scores for whole tumor, tumor core, and enhancing tumor. Really, we care about this one the most. And we have the teacher, the student, and here's the HADNet. And these are the competing networks, including the RSNet, which I had shown you earlier. And you can see that there's a big statistically significant improvement in terms of the enhancing tumor results versus the competing methods. So again, we do well, but again, the numbers don't tell the whole story. So let's just look at some qualitative results for a second. And these are results, so we split the training set into training, validation, and a local testing set so we can really examine the results on the local testing set when we had ground truth. So we can see that the HADNet is the closest to the teacher, particularly for enhancing and necrotic core. So we have here 4 different examples: green, edema, red, necrotic core, yellow, enhancing. So if you look at the example in the 3rd row, you will see that only HADNet is able to correctly identify the absence of a necrotic core here. So compare this, for example, to ground truth. All the other competing methods incorrectly classify the center of the tumor as necrotic core. And in the last row, you can see that the competing methods severely over-segment the necrotic core, a mistake that is less pronounced in HADNet. So there's still room for improvement. There's still some errors that take place. And so I do think there's additional information to be learned from the teacher to avoid this type of error. And again, this brings us back to the notion of uncertainty estimation. So we really do want to quantify the uncertainties to help us present these results to clinicians and to downstream tasks. So what we did is we actually ran our this particular model on the McGill Uncertainty Quantification Challenge, really focusing on the enhancing tumor segmentation. And we showed that HADNet does much better than ADNet in the pre-trained student, where 1 is the best value, and so it outperforms them. So again, let's look at the qualitative results to basically understand this a little bit better. So here we have an example where we have one big enhancing tumor here. And so that white is ground truth. And these are the predictions of HADNet, non-hierarchical HADNet, and the pre-trained student. So one of the things that we wanted to show is green is true positive, red is false negative. So as you decrease the threshold of uncertainty, what you want again is that the green remains, your true positives are correct and confident, and that the red areas here, which are false negatives, start to become yellow, meaning they're uncertain. And so you can see that HADNet has marks the false negative voxels as uncertain compared to the true positive, whereas the other ones, they start to envelop the green area, meaning it's much less confident in the area it's correct about. So again, HADNet's more confident when it's correct and more uncertain when it's incorrect. So this brings me to just some conclusions. Machine learning and deep learning really does have enormous potential to revolutionize medicine and healthcare. We do have a lot of opportunities for new machine learning models, as I've shown, because we have a lot of hard open problems. So we need to develop new machine learning methods to address them. And uncertainty needs to be addressed and not swept under the rug. We need to model the uncertainties. It will help to improve performance, communicate uncertainties to clinicians, I think will increase trust, but also propagate uncertainties across tasks, because we want to avoid accumulating errors and improving performance. So I didn't have time to talk about a lot of other work, I see we're already done, that we've been doing, but I'm happy to talk to you after this talk about any of this sort of new work that we're doing that is relevant, I think, specifically to the cohort here that is working on multiple sclerosis and clinical trials and so on. So we had a short paper at McGill on optimizing operating points for high performance lesion detection and segmentation using lesion size reweighting. And this is really some work that we did in noticing that there's a mix of small and large lesions in a lot of these clinical cases, and standard binary cross entropy loss results in better segmentation of large lesions will lead to the expense of missing the small ones. So if you try to adjust the operating point to detect all the lesions, you generally then get over segmentation of the large lesions. So in that work, we find a way to get this reweighting strategy to kind of overcome the performance gap between the two. The second bit of work, which we're presenting at DART at McGill shortly, is this cohort bias adaptation. One of the things we found is, although we have big data, when we actually naively merged all of our clinical trials, we actually don't do better necessarily in terms of our deep learning results. And so we started to look at why, we've started to see that there's an existence of what we call cohort bias that affects the label distributions. And it's quite complex in terms of cohort bias. It's not just a factor of labeling biases, labeling lesion biases, but also population biological variability across these different cohorts and other things that affect the merging. So in this paper, we propose a generalized affine conditioning framework to learn and account for the cohort bias across these multi-source data sets, which in our case are different clinical trials. And another set of projects that we're working on, which I didn't have time to go into, is we had started to work on predicting the future new MRI lesion activity. So which patient will have new lesions in the future from baseline MRI, and which will also have clinical disability progression. So this is an area of research which is, again, really, really important. And we have some preliminary results for both in early work, but we're working on improving them. We're also working on interpretability. So finding MRI biomarkers for disease worsening or progression, like what was the not just what was the network looking at when it made its prediction, but more in terms of what was the cause. So what are the markers that led to that outcome and that prediction? We're looking at identifying subpopulations of treatment responders. So we do have different arms, treatment arms in the data sets that we have, people on placebos, people on medium risk trials, and people on high risk, high reward trials. And we're really looking now at the notion of treatment responders, which is very complex in the context of MS because of the disease, because you have lesions that appear, disappear, and it's not quite as straightforward as just a tumor shrinking. So we're working quite hard on this, and also on merging different modalities. So how to best use and leverage clinical information, age, sex, and so on, and imaging for better prediction. So with that, I'd like to thank you and thank my group and all of our sponsors. And just again, thank you, Roger, for bringing this up. Shameless plug. We do have a new archive overlay journal. It's actually not that new. It was launched with the special issue of middle 2020. Melba really is there to help bridge the gap between machine learning and the biomedical imaging world. We now have a lot of special issues for different workshops at McGill, also ITME this year, and a lot of other non-special issue papers. And I just want to emphasize it's free. I mean, there's a $10 nominal submission charge, but it's free. It gives the whole model is there, basically built so that people can have control over their papers and have a free model to ensure diversity of the population and avoid sort of paywalls by a more traditional journal. So I encourage you to submit your papers to Melba. This is our team, a team of well-established researchers, and that's it. I thank you for your attention.
Thank you so much, Dr. Arbel. Really, really wonderful talk.
Thank you.
Questions. Let's get to some questions.
I had to do the raise the hand bit, so here I go. Sorry. Sorry, I really enjoyed that, but I'm coming from the world of epidemiology. I'd be really grateful if you could give us a little bit more insight into your observations regarding cohort bias.
Right. Okay, yes. So a little bit more, you mean about this problem. So we've merged different clinical trials. So there are a number of reasons why you could have a cohort bias. So when you're talking about segmenting pathological structures like lesions or tumors, for sure there's going to be different biases. You may have some groups that over-segment, some groups that under-segment, but it's not as simple as just training. When the rater is actually labeling something, they have what's called observational bias. So for example, if I know that this is a late stage patient with a lot of other artifacts in the brain and a lot of atrophy, I may decide that these are not lesions, even though they look like lesions, because I have some contextual information as a radiologist, for example. Then you have cohorts where people are, again, different types of diversity in terms of the populations themselves, older cohort, younger cohort, new early stage, and late stage, and so on. And so when we actually just naively merged without taking it into account, we found a couple of interesting things. When we trained on one cohort, even though, as you've seen, each trial could have like 1,000 patients, it didn't generalize well to the other cohort, meaning the results actually went down quite substantially. So there's an issue of generalizability, which was surprising. And when we actually pooled the data, we found that it didn't actually improve the results, let's say, very well on the first cohort. So we had a way to kind of learn an adaptive cohort affine model that actually learns something about the cohort bias and uses it when it actually performs inference. And we also showed that if you have a new cohort and you just have a small number of labeled patient images, let's say 10 in our paper, and I can invite you to look at the paper, then we can already learn quite a bit about the bias in that specific cohort and actually adapt to it and do well as well. We don't need a lot of data from this new cohort to be able to adapt to it. So I can actually share the link afterwards to that paper. It's kind of preliminary work, but I think we're going to continue to go in that domain as we proceed.
That's great. Thank you very much.
Okay, you're welcome.
Hi, it's David Lee. I was wondering if I could ask you about your real and fake images that you were talking about earlier.
Sure.
When you say fake versus real, are you saying that if you pretend that you don't have the contrast enhanced scan and you use the T1, the T2 and the flare, and then you create the contrast enhanced scan? Is that what was done?
So if you're referring to this particular project, so basically we take 3 images, and what RSNet does is basically synthesize the 4th. So the fake image is actually basically this image here, for example. If I only had these 3 images and I don't have this flare image, this is ground truth.
Yep.
I produce this image, which is a synthesized image, and you can then see the difference between these.
And so you mentioned also that the one that was the most difficult to do was really the T1 contrast enhanced scan.
Yes, particularly, yes, because the enhancement is, we inject the patient with a contrast agent. So obviously there's additional information here, which is hard to synthesize. So this is the synthesized image that we get, and it's not exactly the same enhancement here as this other image.
Right. So the question, and then later you talked about the fact that you're trying to have a situation where you would try and create these T1 contrast enhanced scan because you felt that use of gadolinium was not safe and invasive, and therefore one of the aims of the project was to try and create these T1 contrast enhanced scans. Is that right?
So yeah, so early
without
on,
having to give gadolinium.
That's right. So this image is without having to have gadolinium, but this is a different type of result. So basically what we found is that it doesn't do a great job in synthesizing the enhanced area. And even when we propagated uncertainty, we have some, basically some improvement in the segmentation. So it was all about how are we doing on the segmentation, the downstream task, rather than how well are we doing at synthesizing. So we have an improvement by propagating the synthesized image. We have an improvement by propagating uncertainty, but we only went so far. So the later work is more about, can we do better? Can we actually have a teacher network which learns basically from all the sequences how to segment, and it teaches a student network how to do better when only those 3 images are there. So without the T1C, so that at inference, we would only have deploy the student, the new HadNet student, and the student would then perform segmentation better than it would, much better than it would have otherwise, because it learned something from the teacher.
Right. Yeah, I wanted to understand it because, you know, I think, as you point out, trying to create that T1 contrast enhanced scan is not an easy thing, because it's not just simply a matter of image and the factors there are, because gadolinium is a dynamic process. If you collect the scan at 5-minute versus 10-minute versus 15-minute after injection, it's a very different image altogether.
That's right.
And similarly, if you intervene by giving the patient something as simple as steroids, within an hour, it will look very different.
Yes.
So those
I
are all
agree.
So those are all factors that really make it impossible a task to try and create them. Right.
So you're 100% right. With the clinical trial data set, perhaps we have some control over some of the timings that we might be interested in creating the T1C image, and maybe in surgical planning as well. We can have that kind of knob to some extent. But you are right. The question is also, how much accuracy do we need? Do we need to have, you know, these are dice values, which means it looks at every single voxel and it's trying to get every voxel correct, when really it's kind of hard even for a clinician to get every voxel right. So
for gadolinium enhancement, I mean, the thing about gadolinium enhancement is It's not a matter of getting it right in terms of what the image looks like. It's knowing whether there is gadolinium enhancement or not. Gadolinium enhancement is a physiological thing, and it's not just an anatomical thing. So I think it's critical because, I mean, we joke that we are in an age of fake news and false propagation of information. And I have some concern when I hear the argument that you're trying to do this on the basis of the fact that gadolinium is not safe.
Yeah.
I think there's fake news there.
Okay.
If you talk to clinicians,
yeah.
any pharmaceutical that you give is not safe. But you always have to balance the risk versus the benefit. And the thing about gadolinium is that no one would ever give it indiscriminately, but when it needs to be given, it needs to be given. And the safety part of it is still in many ways theoretical. So I know what you're trying to do, but I think the clinicians that you're working with, if you speak to them honestly, they will tell you that there is a bit of delusional aspect of it if you think that this is going to help them with what they're trying to do. Just my opinion.
So thank you. Yes. I'm for sure, I'm not advocating that at the moment we should not inject the patient with gadolinium. We're not quite there yet at all. I guess my question is for, there are some papers that said that gadolinium does accumulate in the body, although it's
never been shown that it has caused any clinical symptoms.
But so I guess my question.
So I mean, I agree with you. I wouldn't want to have gadolinium if I do not need to.
Right.
But if the question that one is trying to ask has a specific thing, for example, with tumors, you want to be able to see whether it's still enhancing or not versus not enhancing. So if you took that same patient that you're working with and you looked at that patient after they've had radiation, for example, or they've had some treatment, it will look very different on the basis of the gadolinium. The other images may still look very similar.
Right.
And it's the point that I'm trying to make is that because gadolinium is a physiological process for which the images from the T1, the T2, and the flare, it may not be able to pick that out. That's why you give gadolinium.
Right. So, so I agree with you completely, which is why the original problem is there. What I was trying to say was with deep learning, if I give it enough examples of, so that's what's happening here, of all of the images and the output that I care about, which may in some context be detecting the presence at all of gadolinium enhanced tumors or lesions in the brain, or specifically where and how many, and there are many different tasks you might be interested in. So those are the downstream tasks. But if I give the deep learning model enough examples of the different kinds of images, all the sequences, can the deep learning model learn to basically say something general? This person, for example, does have some gadolinium enhancement without, that's why I was saying to take the dice value with a grain of salt. Maybe it doesn't get all the voxels correct, but it does find generally that there is some enhanced tumor here. And so maybe that is already important enough for some tasks if it gets that part correct. That's what I'm saying, like the dice value and so on, which is basically measuring if every voxel is correct, is probably much less important in this, because even the labelers were not always sure maybe about every voxel. So that's why we're also looking at it in the context of multiple sclerosis, where, again, we're looking at a hierarchy of needs. So for gadolinium lesions, you know, the first thing is, does this patient have any gadolinium lesions, enhanced lesions? And so that's a big picture question. Can we teach the student to detect which brains are having gadolinium enhanced lesions even without T1C? And then the next level down is, can we detect them? Can we localize them? Can we find them? And so on. So there's a hierarchy of needs. And I agree with you. It may not be possible to get every voxel right or to find all of them and so on, but perhaps we can assist clinicians by saying, I'm pretty sure I know this patient has some enhancement, some new enhancement. And that's all I can say, for example, maybe not exactly where, maybe, and so on. But there's a hierarchy of problems to be solved, I guess, is what I'm trying to say.
Thank you. As I say, I'd be
Thanks.
happy to talk with you more about it. I
Sure.
don't want to hog the thing from
Sure.
other people, but
Sure.
I think there is a certain lack of understanding there that I think you need to get around.
Michael, thanks for waiting.
Dr. Van, yeah, okay, go ahead.
Okay, hi. Okay, great. Yeah, I really enjoyed the talk. Thank you so much.
Thank you.
Yeah, actually, so with the work on the missing images, like so I guess more generally you could see that as starting down the road towards self-supervised learning, because you're blocking out part of the data and trying to synthesize that. And so yeah, I just wanted to get your thoughts on the promise of doing more of that, because you could of course do all kinds of data augmentation in that way, and then try to learn some latent some 3D latent representation for many things, which which I guess might let you build better models in additional ways. Does that make any sense at all?
Yes, absolutely. Okay. We're looking at self-supervision, and again, I might want to say I'm less interested in getting the synthesis fully correct. I'm more interested in solving the downstream problem of interest, but I do think that self-supervision is definitely something to look at and that we're looking at. The latent representation issue, I think you've nailed it, which is basically what we're doing with the more sophisticated knowledge distillation techniques, basically moving the latent representation of the student closer to the teacher, but doing it at a hierarchy of features, so from global to local features, and to try to kind of pull those features closer to the teacher's features and not just look at the output. And I think that's what's going on in latent representation space. Yeah.
Got it. Great. Thank you so much.
Okay, thanks.
Great, thanks, Michael. If it's okay, I'd like to ask one more question. I'm very, very fascinated by the work on uncertainty. And I'm wondering, with the uncertainty results, or does that inform model development at all? Or do you just write that off as a limitation of the data?
You mean, do we embed it in the network, so to speak? Yeah, there is work on that. The problem with uncertainty, there are many different sources of uncertainty. There's the modeling uncertainty, and then there's, of course, the data uncertainty, which I don't think we're going to necessarily be able to get over fully. In that, for MRI sequences, for sure, we have partial volume, so we have missing ground truth. We have voxels where there are 3 tissues, and somebody makes the call to say it's enhancement or something else. But the truth is, unless we do a biopsy for some of these problems, we don't really have full ground truth in general. And so I don't think that we can fully get away from the notion of uncertainty. I think uncertainty can inform later tasks. So one of the things that I didn't talk about is the issue in MS. So one of the things that we did is we found that if we use a hierarchical MS model, meaning it spits out that I think these are lesions, I'm not sure, I think these are lesions. If you actually propagate that to another network, it learns how to pull apart things that it thinks it's not sure about turn out to be lesions, and other areas where it's not sure about turn out to be non-lesions. And I think that embedding uncertainty in all the different stages is helpful, but I don't think we can fully eliminate the problem of uncertainty in the context of medical imaging, because of the inherent uncertainties in what we're looking at, in the labels and everything else.
Right. Great. Thank you. So I'd like to thank our speaker, Dr. Arbel, again. Thank you so much for giving the talk today and for the great discussion afterwards. And thank you, everyone, for attending today, and wish everyone a great rest of the week.
Thank you so much for having me, and for your great questions and for your attention.
Thank you so much. Take care, everybody.
Thanks.